Our topic for this session is pelvic trauma. Our first case is an intraperitoneal bladder rupture. There is a large amount of intraperitoneal fluid with obvious layering density, which in this case is contrast. The patient has received intravesical contrast, which is escaping here through this small defect in the bladder dome. Of course, intraperitoneal bladder ruptures are typically on the peritoneal aspect of the bladder, and so this is a fairly typical location. They will range anteriorly or posteriorly, but are typically in the dome. And you see there just the one view that clearly shows the defect through which the contrast is escaping. And so that is a case of an intraperitoneal bladder rupture. Our next case is an extraperitoneal bladder rupture. Interestingly, both extraperitoneal bladder ruptures I'll be showing are demonstrated without the aid of intravesical contrast. Obviously, if you do suspect a bladder injury or see any of the ancillary findings that I'll be demonstrating, you should ask for intravesical contrast. Here anteriorly in the anterior abdominal wall and prevesical space, you can see extensive fluid density and stranding. There is a large intraluminal density consistent with a bladder clot. And anteriorly, there is a defect in the anterior bladder wall through which that clot can be seen to pass. There are typical associated skeletal injuries often seen with extraperitoneal bladder ruptures, a sacroiliac diastasis, and a traumatic widening of the pubic symphysis. Let's look first at that intraluminal clot present throughout the bladder, which is itself somewhat distended. Now let's look at that anterior bladder wall defect, through which you can see that hyperdense clot passing and extending into the prevesical space of Retzius. So a nice example of an extraperitoneal bladder rupture with typical associated skeletal injuries. Our next case is another case of extraperitoneal bladder rupture, this one nicely showing the limits of that prevesical space of Retzius. You see anteriorly there is a significant amount of fluid. That is all in the prevesical space of Retzius. You see it posteriorly displacing bowel loops. Lower down in the pelvis, you can see perivesical fluid and a relatively decompressed bladder with a Foley catheter. The sagittal view makes it quite clear that prevesical density extends up to but not beyond the level of the umbilicus. This is bound by transversalis fascia, and that is that structure's superior limit. So here you see all this fluid is in the prevesical space. You can see that it is in fact posteriorly displacing bowel loops, and it is limited to the infraumbilical anterior abdomen. You note as well there is some extraperitoneal stranding in the adjacent pelvis. And here is a nice view of it on the sagittal, essentially defining the prevesical space of Retzius. So that is another case of an extraperitoneal bladder rupture. Our next case is a traumatic uterine rupture. These tragedies are usually related to motor vehicle collisions. You see here an extrauterine fetus, most likely with a few skull fractures as well, and quite a bit of intraperitoneal fluid is obviously present. Lower down, there is a visible defect in the lower segment of the uterus, and there is an ill-defined region there of increased density consistent with clot. There is the extrauterine fetus, and here the clot and uterine defect. And of course, I will run those slower. You can appreciate probable skull fractures with overlapping sutures, not surprisingly. And you can otherwise see the fetus outlined by its subcutaneous fat. In the lower uterine segment, defect and clot, denoting the place of exit for that fetus. So a tragic case of a traumatic uterine rupture. Our next case is a urethral laceration. Of course, these look a lot like extraperitoneal bladder ruptures. There is a great deal of extraperitoneal contrast material. You can see there has been intravesical contrast, but relatively little. There is enough, however, to outline a hypodense filling defect consistent with a clot. You can see here in the periurethral soft tissues, focus of extraurethral contrast and an irregularity of the adjacent urethra consistent with a laceration. This patient has rather typical and expected fractures of the superior and inferior pubic rami. Here on the coronal, you see the extraperitoneal contrast and a nice demonstration of the kinking and the transverse defect there in the urethra with periurethral contrast spilling forth. There is the intraluminal filling defect consistent with a clot, and that was followed by the urethral injury. So again, here is the intraluminal clot, hypodense in this instance as it is outlined by contrast. And then inferiorly, you can see the disrupted circle that is the urethra and periurethral contrast escaping. And there it is on the coronal, a nice view of the transverse defect through it, kinking of the normally straight urethra there. So that is a case of a urethral laceration. Our next case is a penile rupture. Quite a bit of penile edema. Obviously, a great deal of hemorrhage and inflammation are associated with these injuries. You can see, comparing it to the opposite side, a very nice demonstration of a ruptured and deflated corpus cavernosum. You can see it compares very easily to the normal opposite side. So there it is on the movie, that focal defect. We'll go through that a little slower. You can see the nice round intact corpora cavernosa. Watch that right one now. You'll see it is disrupted. The little focus of hemorrhage within it. So that is a traumatic penile rupture, specifically of the right corpus cavernosus. Our next case is a traumatic AV fistula related to a bullet wound. You see anterior to the sacrum there is a metallic fragment. Lower down you can see extravasation anteriorly from the right common iliac artery and filling the right common iliac vein, which is distended and hyperdense. Distally, the effects of that can be seen in the right femoral vein, which is hyperdense and enlarged relative to the normal left femoral vein. That's related to retrograde and premature venous contrast enhancement from an arteriovenous fistula. On the video, you see the arterial defect giving rise to extravasation and filling the right common iliac vein. Now you can see the premature and retrograde enhancement in the right external iliac vein, which is enlarging that vessel as well. So a nice example of an arteriovenous fistula. There is a particular association between bullet wounds and arteriovenous fistulae. I see them quite frequently. This particular case was a bouncer in a bar who apparently ejected one of the patrons, and that person then returned later with a gun to exact his revenge. So that is an arteriovenous fistula. Our last case is an IVC laceration, also related to a bullet wound. This bullet came in at a very high angle. You see this small focus of soft tissue gas in the lower right abdomen is the only external sign. At a higher level, you can see a disrupted anterior inferior vena cava wall with a small focus of venous extravasation. Posterior to that, there is a short segment of absent opacification in the right renal artery. There are small peripheral hypodensities in the right renal cortex that suggest the presence of thromboembolic infarcts. On later views, there is an interesting geographic hypodensity throughout the right renal parenchyma. Lastly, you see a metallic density wedged in the tip of the right ventricle. So let's put this all together through the movies. Follow the inferior vena cava. You see there anterior wall disruption and extravasation. I'll run that through slowly one more time. Follow the inferior vena cava, which is partially opacified. Right there, you see the disruption of the anterior wall and focal extravasation. Let's now look at the right renal artery, that short absent segment of opacification. On the left, there is an absent kidney, and of interest, a pancake adrenal gland visible right there. That's a common finding with developmentally empty left renal foci. So that makes the presence of a right renal artery injury all the more important. You see again those small focal cortical hypodensities consistent with thromboembolic infarcts. Inferior to that, you can see this patient actually has an accessory renal artery, which explains the appearance of that right kidney on delayed images, as that accessory artery preserves the perfusion to the lower portion of the kidney. And lastly, the metallic fragment in the right ventricle. So, what happened? This bullet entered the right groin, passed into the inferior vena cava through its anterior wall, struck the posterior wall of the inferior vena cava, causing an adjacent dissection of the right renal artery, then passed on through the venous system to lodge in the tip of the right ventricle. A very interesting case of bullet embolization, all beginning with an IVC laceration. And that concludes this session on pelvic trauma.